Antihypertensives. Let's go. A lot of drugs here. So, what causes hypertension in the first place? Increased vascular resistance, obviously. Increased venous return, arguably. So, this is going to mean, I guess, two things. One, that we're going to increase the preload, which increases the cardiac output, which also is going to increase the pressure in your systemic circuit. On top of that, I mean, think about it. We have the arterial side and the venous side. What's higher pressure? The arterial side. So if I have increased venous return, that means it's moving through the venous system more quickly, which means that proportionally I'm going to have more blood in the arterial system than normal if they increased venous return. So double reasons why this might also increase hypertension. Increased blood volume also increases the cardiac output, also increases hypertension. So solutions to this: vasodilators and renin-angiotensin-aldosterone system inhibitors. Vasodilators, especially nitrates. Why? Because nitrates disproportionately affect the venous system. So it's going to cause venous dilation, which inhibits venous return. Diuretics and RAS are also going to be good for blood volume. And verapamil and diltiazem are specific L-calcium channel blockers that disproportionately affect the heart. And then beta blockers, which are going to affect the heart rate and the stroke volume. Heart rate maybe a little bit more. So we can really just bundle these into 4 categories. And let's go through these one by one. So within vasodilators, there's just already so many mechanisms of action. I'm specifically talking about the non-renin-angiotensin dilations, because technically those are also vasodilators, but let's table those for now. We'll get to those. So L-type calcium channel blockers, I know I just said that, but I was talking about verapamil and diltiazem. Those are non-dihydropyridines. These are dihydropyridines, which are more going to be for the smooth muscle as opposed to the cardiac muscle. Alpha-1 blockers, which sort of are going to block the effects of norepinephrine, beta-2 and dopamine agonists, which are going to mimic the effects of epinephrine. CMGP elevators, hydralazine, nitrates, nitroprusside, sildenafil, and lastly, sacubitril. I'm sure I'm mispronouncing all this, but who cares? This is going to lead to more angiotensin II and also significantly more of our natriuretic peptides. So we're going to pair these with an angiotensin receptor blocker, which we will get to. All right, don't freak out. We're gonna dissect this, take these things out one by one. All right, let's start here. So GQ pathway. These are G protein coupled receptors. This is going to get our G alpha, which is going to activate phospholipase C, which cleaves a diacylglycerol into or a PIP2 into diacylglycerol and IP3. IP3 is going to go to the sarcoplasmic reticulum and open up a ligand-gated calcium channel so calcium can go out. Who does this? Let's just say it's norepinephrine. Norepinephrine, this is an alpha-1 receptor. So this is alpha-1. Alpha is strong. I'll come back to this. Endothelin is probably the biggest contributor to this. Angiotensin II binds here. Vasopressin binds here as well. Remember that this is norepinephrine over epinephrine. The fact that alpha does not have any E's and norepinephrine has no E's. Calcium, just look. Also, please note that this is vascular smooth muscle. Pretty much everything I've talked about in this lecture has been cardiac muscle, a little bit about skeletal muscle. Maybe we briefly talked about cardiac or the vascular smooth muscle, but this is a smooth muscle cell. Below it, we have an endothelial cell, and below this, we have the vascular lumen, which means the blood is over here. Blood is flowing all around here on the bottom. Okay, so this is talking about a smooth muscle contraction for constriction or dilation of a blood vessel. Let's continue. More calcium, I said, no matter what type of the 3 muscle cells we're dealing with, almost always means more contraction. How in this case? It pairs with calmodulin, which activates MLC kinase, and this is kind of a different than what you're used to on the MCAT. Here, myosin being phosphorylated teams up with actin to cause a contraction. We don't have to worry about calcium binding to troponin or any of that stuff. Not as far as I'm aware. Maybe it's true, but I don't know, and it's not something we're responsible to know. So another way we can, so this is one way you can get a contraction through these GQ alpha-1 receptors. Alternatively, just a L voltage gated calcium channel, a dihydropyridine channel, will allow calcium in. Again, more calcium just means more contraction. Going over to the other side, to the relaxation dilation side, we have our GS agonist. So here, G protein coupled receptor activates G alpha, the heterotrimeric proteins. G alpha is going to move over to adenylate cyclase. Adenylate cyclase generates CAMP, and CAMP is going to do a bunch of different things. Here, CAMP is inhibiting MLC kinase, which we needed to phosphorylate myosin to get a contraction, which means we're going to have the unphosphorylated myosin, which is not contracting, so we are relaxing. And notice that phosphodiesterase can undo this effect. We also have the endothelial cells, which can, with arginine's help, they can generate nitric oxide, which can diffuse over, and this can help convert GTP into cyclic GMP, which now stimulates, so positive versus negative, this now stimulates a phosphatase. So inhibiting the kinase and stimulating the phosphatase are going to have the same general effect. I'm going to be in the relaxation, non-phosphorylated myosin phase. All right, too long didn't read. The left side is associated with more calcium. More calcium means more phosphorylated myosin, which means more contraction. More contraction is going to mean we have constriction, we have narrowing of the blood vessel, and this causes the blood pressure to go up. This other side is against myosin being phosphorylated, which causes a relaxation, which is a dilation, which means that the blood pressure will go down. So important to know who is an alpha-1 receptor binder, who is a GS. Notice that this is a beta-2 binder. And let's actually focus on the epi for a second. So, okay, let's say I release some catecholamines. Catecholamines are supposed to cause net vasoconstriction. Yeah, they cause some vasodilation in certain parts of your body and vasoconstriction in other parts of your body, but it's a net vasoconstriction. And how do we get that if we have epinephrine and norepinephrine in equal amounts? First of all, they might not be in equal amounts, but let's table that. Let's pretend they're in equal amounts. The idea is that, so I said, we'll come back to this. Alpha is strong, beta is weak. The alpha-1 receptor constriction is more dominant over the beta-2 receptor vasodilation. So that is important. Okay, well, let's go to the next thing. What if I have a beta blocker? Beta blockers are supposed to reduce. Let's say it's a non-selective beta blocker. So it's B1 and B2, and forget about A. It's just interacting with B1 and B2. B1 is stimulating the heart. B2 is causing vasodilation. So if I inhibit both of those, causing the heart to work less hard, and I'm also going to inhibit vasodilation, which causes actually a vasoconstriction. I'm going to say that again. Non-selective beta receptor blockers are going to cause a mild vasoconstriction, but the emphasis on mild. That is overshadowed, the B2 effect, by the B1 effect. So B1 is the name of the game for beta blockers. What they do with beta 2 is not as important at all. On top of that, a third thing, two beta blockers that we'll get into are going to be non-selective, even more non-selective. So non-selective in the sense that they actually have no preference for alpha or beta binding. So they will inhibit alpha receptors and beta receptors. And again, beta 2 it's weaker than beta 1 and it's weaker than alpha 1. So forget about it. If you look at the super non-selective beta receptors, I'm inhibiting alpha 1, which means I'm inhibiting vasoconstriction, causing a vasodilation, reduces pressure. That's what we want. Reducing the afterload. We're trying to take pressure off the heart. Additionally, this is also going to inhibit the beta 1 receptors of the heart. So its contractility and its rate are going to go down, which allows it more time to refill during diastole, all that, et cetera, et cetera, et cetera. Woo! Okay, glad I got that out of the way. Elephant in the room. All right, let's look at so alpha-1 blockers specifically. So specific alpha-1, forget about beta. Doxazosin and prazosin. Sildenafil is going to inhibit PDE5. This phosphodiesterase is trying to convert cGMP into GTP, which would inhibit this, which would cause a contraction. That's what PD5 does. But this is inhibiting the inhibitor. So long story short, sildenafil increases the amount of cGMP we have, which increases relaxation. What is the effect of more blood flow for Viagra? Somehow it disproportionately affects the penis. Blood flowing into the penis is going to cause an erection. And so that's the whole point of Viagra. And the dipines are going to be calcium channel blockers. So we're going to go through these a little bit more. Also notice that just another mnemonic, beta 2. So if we're just thinking about vasodilation, the alpha 1 versus beta 2, alpha has no E, so we know it's norepinephrine. And for the beta 2, we see that there is an E, so this is for epinephrine. And again, this is specifically for the alpha 1, beta 2 exchange, which has to do with vasodilation, vasoconstriction. Now, what about beta 1 versus beta 2? I always think of 1 comes before 2, and the heart becomes before the vessels, like the arteries. Yeah. Okay. Calcium channel blockers, we already went over this. The dihydropyridines, the dipenes are amlodipine and nifedipine. So the idines, dipenes, kind of checks out. Verapamil and diltiazem are for the heart. So those are non-dihydropyridines. They're in a different category. So forget about them. At the end of the day, remember, calcium in the heart means contraction. So no calcium, no contraction. We're preventing contraction, which means we have a dilation. We want to reduce the blood pressure. This whole section is antihypertensive medications. All right, you should probably know this, but right now let's just keep it a little bit simpler. Even more simpler, forget about alpha 2, not important. So for alpha 1, this is going to be for constriction. This is pro-vessel constriction, increasing blood pressure. This is norepinephrine over norepinephrine. And remember that alpha has no E, this has no E. All right, what about beta 2? Beta 2 is for vessel dilation. This has an E, which means we're dealing with epinephrine, not so much norepinephrine. This is going to lower the blood pressure. So raise the blood pressure, lower the blood pressure, and this is of course the opposite effect if we're talking about blockers. Beta 1 comes before 2, the heart becomes before the vessels. Equally epinephrine and norepinephrine effects. I think that's really important to know, not just for this test. It's going to keep coming up again and again and again in future sections. We talked about this. These two are alpha blockers. Fun. All right, so a lot of these are causing, stimulating GS. We might recognize a lot of these as vasodilators, maybe not epinephrine, but it's good to know that epinephrine is actually a vasodilator. Adenosine is an important vasodilator, but now there's a random one, phenaldipam. It's actually a dopamine receptor, but somehow it can vasodilate, very similar to the beta 2. So I'm just going to treat it as interchangeable. So these 4 things are going to elevate cGMP levels. So hydralazine, I don't really know the mechanism, somehow elevates this, which activates this, which causes relaxation, vasodilation, lower blood pressure. Nitrates can sort of, I don't know if they generate NO or they mimic NO, because I think it's just usually just NO3 minus, but not important. They're going to cause NO to increase, which causes more cGMP, which causes this to be activated, which again causes relaxation. So really the same effect. Nitroprusside, the prusside here is also just increasing NO, which does the same thing. And then sildenafil, we said, is inhibiting PDE5, which is trying to degrade cGMP. So we'll have more cGMP, which means we have more MLC phosphatase, which means we have more relaxation, more dilation. Now, you're not supposed to pair nitrates with sildenafil because this is going to be like a synergistic increase in cGMP, which means we have massive vasodilation, which means you're going to have massive hypotension. So you cannot pair these together. Additionally, keep in mind that the nitrate vasodilation has a larger effects on the veins, which is going to decrease the preload and less stress at the heart, lower the blood pressure. So sacubitril is a neprilysin inhibitor. What the heck's a neprilysin? Neprilysin is a proteolytic degradative enzyme that breaks down many different things, specifically what we're concerned with, angiotensin 2 and the natriuretic peptides. So it's so I'm inhibiting the thing that breaks both of these down, which means I'm going to get more angiotensin 2, and I'm also going to get more ANP and more BNP. Well, let's think about what the effects of these are. Angiotensin 2 constricts blood vessels, and it calls for aldosterone, which raises sodium levels, which cause osmosis, which raises the blood volume and preload. ANP and BNP completely counteract those 2 effects. They're going to cause vasodilation. They're also going to inhibit the effects of aldosterone. And if you think about the name, nat means sodium and uretic means peeing out. We're going to pee out sodium, which means we pee out more water. That's how you can remember it's the exact opposite effect. But if this is causing increased blood pressure and these are causing decreased blood pressure, if I have a neprilysin inhibitor, which is sacubitril, isn't that kind of a wash? Doesn't that break even? Yeah, I suppose it would. So which is important why we have to pair this with an angiotensin 2 receptor blocker. So now I'm actually blocking this. So we just have these. So we are actually decreasing the blood pressure, which is our overall goal. All right. The liver makes angiotensinogen. Inogen is a zymogen. It's not active. The kidney makes renin. Renin activates angiotensinogen and angiotensin 1. Lungs make ACE. ACE is angiotensin converting enzyme, converts 1 to 2. Angiotensin 2 goes ahead and causes vasoconstriction, which increases blood pressure. It also goes to the adrenal gland and recruits aldosterone, which causes sodium reabsorption in the kidneys, which importantly raises the amount of water in the blood. The water in the blood is going to raise the blood pressure. That is the RAAS, renin-angiotensin-aldosterone system. So this drug kills renin, stops the whole thing, lowers the blood pressure. So we're talking about the RAAS inhibitors now. An ACE inhibitor is, I just substitute the CE for PR and add an L. So anything that is in pril inhibits ACE, no angiotensin 2, lowers the blood pressure. Boom. Angiotensin 2 receptor blockers, also known as ARBs. This is losartan, candesartan, valsartan. I just think of sartan as in like Spartan. And I always thought of angiotensin 2. Angiotensin 2, in my opinion, is really it actually does a lot of stuff. It interacts with the heart. It goes this. I always thought of this as like the beast. It's the most dominant of the RAAS system. And so I imagine that if you want to take down angiotensin 2, you're going to need a really, really tough drug. And that's where these Spartan drugs come in to take away the angiotensin 2. Usually this is people who are refractory, who are not responding to ACE inhibitors. So it's usually going to be secondary. Diuretics. So we had the vasodilators that were non-ROS. Then we had the ROS, and now we're going to have diuretics. We have loop diuretics, thiazide diuretics, and you have potassium-sparing diuretics. We will come back to this. Actually, no. We'll come back to this. So thiazide is going to be probably our main go-to because of a lot of side effects the other ones have. The loop diuretics is furosemide, and the potassium-sparing is spironolactone. So specifically, spironolactone is it's an aldosterone antagonist, and it is so you can think of it as a diuretic. 2, you could technically think of it as a renin-angiotensin-aldosterone system inhibitor because aldosterone is, this is going to be playing a role in diuresis, but also a role in the ROS system. So who cares about categorization? Just it could theoretically fall under either of those umbrellas. So this drug works by mimicking aldosterone. Notice it ends in -one. It is one of those non-polar hydrophobic, things like testosterone, progesterone, cortisone, aldosterone. These are cholesterol, steroid derived. Which one is which? Can you tell? Neither can the cell, right? So technically this one is aldosterone, this one is spironolactone, and this one is testosterone. The idea is it is an antagonist to aldosterone, which is how we get the antihypertensive effects, but it's also going to screw with the testosterone and estrone effects, which is going to cause some side effects that we'll get to. Heart inhibitors, I'm sure there's a better way to put it. You could just say negative inotropes or negative chronotropes. Who cares? Calcium channel blockers. Now, again, L-gated. These are non-dihydropyridines. We're talking about verapamil. We're talking about diltiazem. And the beta-1 blockers. Again, beta-1 blockers might be interacting with beta-2, might be interacting with alpha. We'll get to that. Anything ending in olo or all is going to be a beta blocker. So these two, non-hydro L-type, these are also known, we're going to see these are type 4 antiarrhythmics. So type 4 antiarrhythmics are also calcium channel blockers. They're technically antihypertensive. They're also antiarrhythmics. So it's going to slow down phase 2, which is relying on calcium influx. And so we're going to have a weaker contraction, and it's taking a little bit of stress off the heart, and it's going to reduce the blood pressure as well. Now, this calcium influx, remember the L-type calcium channels are both in pacemaker and in the cardiac myocytes, unlike the T, which are just in the pacemaker. So this is also going to block the pacemaker L channels, and it's going to slow their conduction. It's going to, maybe elongate their repolarization, and this might lead to an AV block of the. Just might cause an AV block for that reason. So. Beta-1, again, is heart stimulation, 1 before 2, heart before vessels. And beta-1, usually when we say beta blockers, we're mostly just talking about the effects on the heart. Yeah, other effects might be there, but we're mostly concerned with the heart effects. So it's going to be a beta receptor is going to increase the contractile force, positive inotropy. It is going to increase the rate of contraction, so positive chronotrope. So technically, when I say slower conduction, really what I'm talking about is the beta blockers are going to undo this and undo this through slower conduction. So beta increases all this crap, and the beta blockers undo all of this crap. And too much beta receptor activation or inhibition could also lead to arrhythmias. Remember that we have phase 4, the funny current, sodium comes in. Then we have the T, timely calcium channels. They then quickly close, and the L, which is, I think of late because they're later, but they're also longer lasting. L calcium channels open, specifically pacemaker cell. This is going to be an influx. Calcium comes in, they close, then the potassium channels open. So after we depolarize, now we're going to repolarize, and this is effectively going to designate what the heart rate should be. Most important, the diastolic depolarization that we have here in phase 4. So the way that the catecholamines work is by altering phase 4 slope or phase 4 slope. It's going to increase it with sympathetic, and it's going to decrease it with the vagus or parasympathetic. So that's the effects on, so the beta blockers are inhibiting those effects. So the vagal is going to be really, if we inhibit the sympathetic, this is going to be the same thing as the beta blocker. So we're going to have a slower phase 4 slope for our beta blockers. So that's the pacemaker. What about the cardiac myocytes? We are going to have, I should say, weaker. So beta 1 is going to cause stronger contractions. We're going to have more CAMP, which stimulates ryanodine receptor, dihydropyridine receptor. So this is L-gated calcium. Calcium gets into the cell. More calcium in the cell means more contraction. Specifically here, calcium-induced calcium release is going to interact with the ryanodine receptor, which unleashes calcium from the sarcoplasmic reticulum to the SERCA protein is trying to pump calcium after contraction back into the sarcoplasmic reticulum. It's lusitropy, it's relaxation, so that we can have more calcium in for a subsequent following contraction. Phospholamban inhibits that. Well, you know what? Beta 1 inhibits that, which means more SERCA, which means more relaxation, which means better contractility. And we talked about the pace just now. And again, beta 1 blockers are just undoing all this crap. So for beta blockers, this I think is really helpful. A to M is going to be beta 1 selective. So in other words, beta 1 effect is more than beta 2. Again, that should always be kind of a default assumption that beta 1 is a little bit more than beta 2. Even when we're equally affecting beta 2 is just not that strong compared to beta 1. But beta 1 is just think of it as the beta 1. So for the first half of the alphabet, notice A, B, B, E, M. Esmolol here is bolded because this is very fast acting, so this is giving it intravenously in an emergency setting. M to Z, this is going to be for the second half of the alphabet, nadolol, pindolol, propanolol, timolol. This is beta 1 and beta 2. So if I'm inhibiting beta 2, remember that beta 2 is a vasodilator, means it's going to be causing a little bit of vasoconstriction. So that is going to increase the blood pressure. But again, remember, that is offset by the decrease in blood pressure that is achieved by inhibiting the contractility and heart rate that the beta 1 will induce. So non-selective. So, this is non-selective, but this is really non-selective. Like, I'm open-minded, but you're really open-minded. So this is alpha and beta. There is no olol. This is, I think, really helpful, right? Everything else was olol, etc. This is now ilol, alol. They just got to be different. So remember, this is inhibiting beta 2 and inhibiting alpha 1, right? We have a vasodilation for beta 2 and a vasoconstriction for alpha 1. So if I'm hitting both of those, is it a watch? No. Remember, alpha means strong, beta means weak. So the alpha 1 effects are going to overshadow and dominate the beta 2 effects. So if I'm inhibiting alpha 1 that has a really large effect compared to inhibiting beta 2, alpha 1 wants to vasoconstrict. So if I inhibit it, it's going to cause a vasodilation. Whew! All right. So just to kind of tie this up a little bit, beta blockers, if I have a selective, again, this is the first half of the alphabet. This atenolol and metoprolol are going to decrease the contractility and heart rate, which decreases the cardiac output, which lowers the blood pressure. Yay. Non-selective, it might even work better. Remember, these are the ones that don't end in olol, alol, and ilol. And yes, same effects on the heart because these are non-selective. They're going to affect beta, but they're also going to affect the alpha. And remember that we don't really care about the beta 2 compared to the alpha 1. So By inhibiting the vasoconstriction, we're causing a vasodilation. This is going to decrease systemic vascular resistance, also known as TPR, total peripheral resistance, and it's going to lower the blood pressure. Additionally, I would know that beta 1 also stimulates the kidneys to secrete renin, which activates the renin-angiotensin-aldosterone system. So with our beta blockers, we're inhibiting beta 1, and this is going to lower the renin-angiotensin-aldosterone system. I don't actually know why that's not shown over here, but who cares? But that is just maybe another effect of beta 1 as well. Antihypertensives. So let's just go through a little summary. L-type calcium channel blockers, dihydropyridines known as dipines. Alpha-1 blockers were the Zosyn. Beta-2, which was really just a dopamine agonist, is phenaldipam. CGMP, we had 4, hydralazine, nitrates, nitroprusside, and sildenafil. As if you're an EMT, you give this to people a lot. But remember not to pair it with people who have Viagra. Remember that Jack Nicholson bit from like It's Complicated or whatever the movie is. Something's got to give. I don't remember. They're all the same. They're all delightful, but they're all the same. This inhibits the breakdown of AMP and BMP and also inhibits the breakdown of angiotensin 2. Those would offset one another if we did not pair it with an angiotensin receptor blocker, so we just have the AMP and BMP left over. The blocking the renin system, let's just kill renin. Let's kill the angiotensin converting enzyme with the prils. Let's block the angiotensin 2, which is the really tough one. So we need a Spartan of a drug, the sartans to counteract this. And then aldosterone is counteracted by spironolactone. Loop diuretics. It's really just, it should say diuretics. Diuretics, we have 1 loop furosemide. We have the thiazide, which has chlor or thiaz in the name. And then the potassium-sparing diuretics, spironolactone. Remember that there's kind of a link here. Who cares where we categorize it? Just know what it does. Heart slowers, I love it. Calcium channel blockers. These are type 4 antiarrhythmics, specifically verapamil and diltiazem. These are non-dihydropyridines. Beta 2 blockers are type 2 antiarrhythmics. OLOL means that we're dealing with the first half. So they all end in OLOL. But now more specifically, if I'm the first half of the alphabet in terms of the name for the beta blocker, it's beta 1 selective over beta 2. Remember that even if it does affect beta 2 effect is counteracted by the beta 1. So the non-selective is going to be the second half of the alphabet, like propranolol, and this is going to be beta 1 and beta 2 equally. And then if it's fancy-pantsy suffix ilol or alol, then it's going to be A and B. And remember that what we're really concerned with is that, or interested in, is the fact that this is going to inhibit the alpha-1 receptor. Alpha-1 causes vasoconstriction, so this causes a vasodilation in addition to slowing down the heart. So it's sort of like doubly useful. Side effects. If you have all these vasodilators and anti-ROS things, this could cause hypotension, right? Maybe it goes too far, right? You want to lower the blood pressure, maybe it lowers it too far. In addition, if you lower the blood pressure, you might have like a baroreflex response where a compensatory tachycardia develops. And again, do not pair nitrates with sildenafil, as shown in this fun Jack Nicholson movie, causes massive vasodilation and hypotension. The Spartans, the kilrenins, and the prils, aprils, these can cause hyperkalemia. Why? Because aldosterone, yes, it reabsorbs sodium, yes, it reabsorbs water. It also secretes potassium. And so if I don't have aldosterone working, I'm going to have more potassium. It's not being secreted, which means I'm going to have hyperkalemia. And again, hyperkalemia can affect the heart rate in various ways. It's going to slow the phase 0 upstroke, and it's going to increase the phase 3 downstroke, and it's going to shorten the refractory period. And it can be counteracted by insulin and calcium. Fun. ACE inhibitors, angioedema. Why? Because ACE also breaks down bradykinin. Bradykinin causes dilation, especially dilation of the face, which we can see here. Thiazide diuretics cause the opposite. Hypokalemia, potassium-sparing diuretics. It's in the name. This is going to cause an increase in calcium. Why? Well, remember, these are just the same thing. This is really just this, right? This effect was because aldosterone's effect is not being heard. This is more direct. This is just literally directing the aldosterone. So it's going to cause the exact same thing. In addition, remember that spironolactone also kind of mimics testosterone and estrone. So we might get gynecomastia and amenorrhea. So Men might develop breasts, and women's periods might stop. Calcium channel blockers, gingival hyperplasia, I think is pretty specific. And then the non-dihydropyridines, the AV block, because the calcium is necessary for conduction velocity and refractory period for a pacemaker cell. Nitroprusside randomly has cyanide that gets released. Beta blockers, type 2, and calcium channel is type 4. AV block. Sometimes, so this is a debate that I think has been overturned, but we'll just talk about it. So sometimes people say if somebody shows up to the ER and they've been doing a lot of cocaine and they also have a heart issue, you don't want to give them beta blockers. Why? Because cocaine causes alpha vasoconstriction. And if I give somebody a beta blocker, assuming it's not one of those super duper open-minded non-selective ones where it's just affecting the beta system, if I am inhibiting a beta 2, so let's say that this is the second half of the alphabet, like propranolol. So beta 1 and beta 2 equally. Let's just forget about beta 1, focus on beta 2. If it inhibits beta 2, it's inhibiting the vasodilation, which means we're inhibiting vasodilation in addition to the fact that cocaine is massively constricting via an alpha 1 mechanism. So this could cause a hypertensive crisis, massive vasoconstriction. So sometimes people say that this is a contraindicated. I think this is debated. Maybe it's been overturned. I don't really know, but just maybe just be aware of it. Hypoglycemic masking. People often develop hypoglycemia for whatever reason on beta blockers, and this. I guess it makes sense if you think about the fact that beta blockers, the catecholamines are going to be responsible for breaking down glycogen, and if you don't break down glycogen and put it into the blood, then you might become hypoglycemic. Somehow the beta blockers mask this, though, so it's hard to tell. In any case, you might want to supplement with things like glucagon to increase the blood sugar just to be on the safe side.